Question 1. A 55-year-old female patient presents with chronic pain and stiffness in the knees, particularly after prolonged periods of activity. Upon physical examination, the patient exhibits limited range of motion and crepitus in both knees. X-rays show joint space narrowing and the presence of osteophytes. Based on these findings, which of the following conditions is the most likely diagnosis? A. Rheumatoid arthritis. B. Gout. C. Osteoarthritis. D. Bursitis. Answer: C. Osteoarthritis. Explanation: osteoarthritis (OA) is the most common form of arthritis, particularly in older adults. It is characterized by the degeneration of articular cartilage and the formation of osteophytes, bone spurs, which leads to joint space narrowing and stiffness, especially after activity. The patient's history of chronic knee pain, limited range of motion, crepitus, and radiologic findings of osteophytes are typical signs of OA. Rheumatoid arthritis (RA) is an autoimmune condition that affects joints symmetrically and can cause morning stiffness and systemic symptoms, which is not consistent with this patient's presentation. Gout primarily affects the big toe and is associated with hyperuricemia, not the knee joint or the radiographic findings described. Bursitis would involve inflammation of the bursa and would not typically show the characteristic jaw changes observed in this case. Question 2. Mr. Hernandez, a 70-year-old male, is recovering from a total knee arthroplasty. He is currently being discharged from the hospital, and his physician has recommended early mobilization and range of motion exercises. Mr. Hernandez is concerned about pain and discomfort during his rehabilitation process. Which of the following is the most appropriate initial approach to managing his postoperative pain and supporting his rehabilitation? Administer narcotic pain medications for the first few weeks postoperatively and limit range of motion exercises to avoid stress on the knee joint. B. Use a combination of non-pharmacological interventions like heat therapy, TENS, and a prescribed home exercise program that includes gradual range of motion exercises. C. Administer muscle relaxants and corticosteroids immediately after discharge to minimize swelling and postponing any exercise. D. Discontinue all pain medications and encourage only active participation in rehabilitation exercises to accelerate recovery. Answer: B. Use a combination of non-pharmacological interventions like heat therapy, TENS, and a prescribed home exercise program that includes gradual range of motion exercises. Explanation: postoperative pain management in orthopedic rehabilitation should incorporate both pharmacological and non-pharmacological interventions to ensure comfort while promoting mobility. Non-pharmacological methods such as heat therapy, transcutaneous electrical nerve stimulation, TENS, can help alleviate pain, while range of motion exercises should be performed gradually to promote recovery without overstressing the joint. Narcotic pain medications should be used sparingly due to the risk of dependence and side effects. Limiting movement is also counterproductive to the recovery process. Muscle relaxants and corticosteroids may be used in specific cases, but are not first-line interventions for general postoperative rehabilitation. Discontinuing pain medications entirely would cause unnecessary discomfort and hinder recovery. Question 3, scenario-based. A 45-year-old male patient arrives in the emergency room following a fall from a ladder, during which he landed directly on his left leg. The patient reports severe pain, inability to move the leg, and visible deformity in the mid-thigh region. Upon physical examination, there is marked swelling, bruising, and tenderness over the femur. X-rays reveal a comminuted fracture of the femoral shaft. Which of the following is the most important next step in managing this patient? A. Immediate casting of the leg and discharge to home care with instructions for weight-bearing exercises. B. Apply a splint to stabilize the fracture and arrange for surgical consultation to assess the need for internal fixation. C. Administer antibiotics and pain medications before performing an open reduction and internal fixation procedure. D. Begin physical therapy immediately to restore movement and prevent further complications. Answer: B. Apply a splint to stabilize the fracture and arrange for surgical consultation to assess the need for internal fixation. Explanation: a comminuted fracture of the femoral shaft requires stabilization to prevent further injury and reduce pain. Immediate management includes applying a splint to immobilize the fracture and prevent further displacement until surgical intervention can be performed. The patient needs to be assessed by an orthopedic surgeon to determine if open reduction and internal fixation or if it is necessary to stabilize the bone properly. Immediate casting is not appropriate due to the complexity of a comminuted fracture, which may require surgical intervention. While antibiotics and pain medications are important, the priority is stabilizing the fracture and planning for potential surgery. Physical therapy should not be initiated until after the fracture has been stable, and it is not an immediate priority in this situation. Question 4. A 60-year-old female patient is diagnosed with osteoarthritis OA in both knees. She reports difficulty walking and experiences significant pain with activity, especially when climbing stairs. The physician recommends a total knee arthroplasty (TKA) as a treatment option. During her preoperative visit, she expresses concerns about the potential risks associated with surgery, particularly infection. Which of the interventions is the most important for reducing the risk of postoperative infection in this patient? A. Administer prophylactic antibiotics prior to the incision and for 24 hours postoperatively as per established surgical protocols. B. Delay surgery until the patient's osteoarthritis has worsened further, as infection is less likely to occur in advanced cases. C. Avoid preoperative antibiotic administration and rely solely on proper sterile techniques during surgery to reduce infection risk. D. Encourage the patient to aggressive postoperative rehabilitation to enhance immune function and prevent infection. Answer A. Administer prophylactic antibiotics prior to the incision and for 24 hours postoperatively, as per established surgical protocols. Explanation: the administration of prophylactic antibiotics before surgery and for a short period postoperatively is a standard practice to reduce the risk of infection in patients undergoing orthopedic surgeries, such as EKA. The antibiotics are typically given within 1 hour of the to ensure they are effective in preventing surgical site infections. Delaying surgery based on the idea that infection is less likely with advanced osteoarthritis is incorrect. In fact, delaying surgery could increase the risk of complications. Proper sterile techniques during surgery are important but should be supplemented with antibiotic prophylaxis for optimal infection control. Postoperative rehabilitation is essential for recovery but does not impact infection prevention, which is the focus in the immediate perioperative period. Question 5. A 72-year-old male patient is recovering from a laminectomy procedure to treat spinal stenosis. He is complaining of persistent pain in his lower back, accompanied by numbness in his left leg. His surgical incision site appears well healed, but he is concerned that the persistent symptoms may indicate a complication. What is the most likely cause of his current symptoms, and what should be done next in his care plan? A. The symptoms are most likely due to nerve root irritation, and he should be referred for physical therapy and prescribed muscle relaxants. B. The symptoms are indicative of a deep vein thrombus (DVT), and immediate imaging should be performed to confirm the diagnosis. C. The symptoms suggest a recurrence of spinal stenosis, and an MRI should be scheduled to evaluate for any new compression. D. The symptoms are a normal part healing process after spinal surgery, and no further action is needed unless the pain worsens. Answer C. The symptoms suggest a recurrence of spinal stenosis, and an MRI should be scheduled to evaluate for any new compression. Explanation: persistent symptoms such as low back pain and leg numbness after a laminectomy could indicate that the initial spinal stenosis has recurred or that there is new compression on the nerve roots. MRI is the most appropriate next step to assess for any structural changes in the spine, such as stenosis or disc herniation. While nerve root irritation can occur after spinal surgery, this patient's symptoms warrant further investigation with imaging to rule out recurrence of stenosis. Deep vein thrombus (DVT) would typically present with swelling, redness, and warmth in the affected leg, which is not consistent with this patient's presentation. While some discomfort can occur during the healing process, the persistence and nature of this patient's symptoms require further investigation. Question 6. Mr. Clark is a 58-year-old male who presents with a diagnosis of osteoporotic vertebral compression fractures after a fall. His medical history includes osteoporosis, hypertension, and a previous myocardial infarction. He is concerned about the long-term management of his condition and prevention of future fractures. What is the most appropriate pharmacological intervention for Mr. Clark's osteoporose? Prevent further fractures. A. Bisphosphonates such as alendronate, as they inhibit bone resorption and help increase bone mineral density. B. Selective estrogen receptor modulators, SERMs, such as raloxifene, which are more effective in men for preventing fractures. C. Calcium and vitamin D supplementation alone, as these are the most important factors in preventing fractures. D. Corticosteroids to reduce inflammation and promote bone healing, as Mr. fractures are acute. Answer A. Bisphosphonates such as alendronate, as they inhibit bone resorption and help increase bone mineral density. Explanation: Bisphosphonates like alendronate are the first-line pharmacological treatment for osteoporosis in patients at risk for fractures. They work by inhibiting osteoclast-mediated bone resorption, which helps to increase bone mineral density and reduce the risk of future fractures. SERMs like raloxifenate, used for postmenopausal women but are not as effective in men. While calcium and vitamin D are essential for bone health, they are not sufficient alone in the management of osteoporosis to prevent fractures. Corticosteroids are not recommended for treating osteoporosis and may, in fact, contribute to bone loss if used long-term. Question 7. A 30-year-old female patient presents with a recent diagnosis of bilateral carpal tunnel syndrome. She reports numbness and tingling in both hands, which is particularly noticeable at night. The symptoms have progressively worsened over the past few months. After a thorough assessment, the physician recommends non-surgical management, including wrist splints and corticosteroid injections. However, the patient is concerned about the potential side effects of corticosteroids. Which of the following is the most accurate information to share with the patient regarding the use of corticosteroid injections in her case? A. Corticosteroid injections are safe and have no side effects and will completely resolve the symptoms of carpal tunnel syndrome. B. Corticosteroid injections may provide temporary relief by reducing inflammation, but their effect is often short-lived and should not be used frequently. C. Corticosteroid injections should be avoided entirely in patients with carpal tunnel syndrome as they may worsen the condition in the long term. Corticosteroid injections are only effective for patients who are considering surgery, and they do not provide any benefit in non-surgical cases. Answer. B. Corticosteroid injections may provide temporary relief by reducing inflammation, but their effect is often short-lived and should not be used frequently. Explanation. Corticosteroid injections are commonly used in the non-surgical management of carpal tunnel syndrome to reduce inflammation and relieve symptoms temporarily. However, their effects are typically short-term and repeated use may carry risks, such as tendon damage or symptoms. While corticosteroids are effective for short-term relief, they do not provide a permanent solution, and the patient should be educated on managing the condition through splints, ergonomic adjustments, and physical therapy. Corticosteroid injections are not contraindicated in carpal tunnel syndrome but should be used cautiously and infrequently to avoid complications. These injections are not reserved solely for patients considering surgery. They can be an appropriate part of conservative management. Question 8. A 65-year-old male patient with a history of spinal stenosis and degenerative disc disease undergoes a lumbar laminectomy. Following the surgery, the patient experiences significant pain and difficulty with movement. He has been prescribed opioid analgesics, but he is concerned about the potential for dependency and the side effects of the medications. What is the most effective approach to pain management in this patient to his concerns while promoting optimal recovery? A. Continue the opioid analgesics as prescribed with no other interventions to ensure the patient is comfortable during recovery. B. Wean off opioids as soon as possible and incorporate multimodal pain management strategies such as NSAIDs, physical therapy, and non-pharmacological interventions. C. Use opioid analgesics indefinitely to control pain and ensure the patient can fully participate in post-operative rehabilitation. Discontinue all opioid medications immediately and rely solely on non-pharmacological interventions such as massage therapy and heat packs. Answer. B. Wean off opioids as soon as possible and incorporate multimodal pain management strategies such as NSAIDs, physical therapy, and non-pharmacological interventions. Explanation. Multimodal pain management is the most effective approach for post-operative pain, particularly after spinal surgery. This strategy combines the use of opioid analgesics for short-term relief with other non-pharmacological and pharmacological treatments to reduce dependency risks and promote recovery. Opioids should be used for short-term pain control only with a focus on reducing their use as the patient recovers. Relying solely on opioids or discontinuing them immediately could result in inadequate pain control or lead to excessive reliance on non-pharmacological treatments that may not sufficiently manage the pain. A combination of NSAIDs, physical therapy, and modalities like TENS or heat therapy should be considered to support patients' healing and improve functional outcomes. Question 9. A 55-year-old male patient is diagnosed with a rotator cuff tear and is being prepared for arthroscopic surgery. He is concerned about the potential for long-term disability and asks about the expected recovery time and rehabilitation process. Which of the following is the most accurate information to provide to this patient regarding the post-operative rehabilitation following rotator cuff repair surgery? A. The patient can resume full activity immediately following surgery and should focus on strengthening exercises. B. Full recovery typically takes 1 to 2 months, and the patient should follow a structured rehabilitation program to regain strength and mobility. C. No physical therapy is required after the procedure, and the patient can return to normal activity in a few weeks. D. The patient should avoid all movement of the shoulder for up to a year to ensure proper healing. Answer: B. Full recovery typically takes 1 to 2 months, and the patient should follow a structured rehabilitation program to regain strength and mobility. Explanation: after a rotator cuff repair, full recovery can take several months, typically 6 to 12 months, as the healing process requires time. Rehabilitation is crucial for regaining strength and mobility, with a focus on passive range of motion exercises initially, followed by exercises as healing progresses. Immediate resumption of full activity is not advisable, as the tendon requires time to heal properly to avoid re-injury. Physical therapy is essential for the recovery process, and early mobilization is encouraged within the structured rehab protocol. Avoiding movement for an extended period could lead to joint stiffness and hinder recovery. Question 10. A 65-year-old woman with a history of breast cancer treated with surgery, radiation, and chemotherapy several years ago presents with sudden onset of shortness of breath and chest pain. She is tachypneic and hypoxic, and her X shows no signs of myocardial infarction. Chest X-ray reveals a large right-sided pleural effusion. What is the most likely cause of her symptoms, and what is the appropriate next step in management? A. Pulmonary embolism. Initiate anticoagulation therapy and obtain a pulmonary angiogram. B. Malignant pleural effusion. Perform thoracentesis to confirm the diagnosis and manage accordingly. C. Pneumonia. Initiate broad-spectrum antibiotics and monitor for improvement. D. Congestive heart failure. Begin diuretics to relieve fluid buildup and monitor for improvement. Answer: B. Malignant pleural effusion. Perform thoracentesis to confirm the diagnosis and manage accordingly. Explanation: this patient's history of breast cancer, combined with her symptoms of shortness of breath, chest pain, and large pleural effusion, raises concern for malignant pleural effusion. Malignant effusions often occur in cancer patients and require thoracentesis for diagnostic confirmation. The fluid can then be analyzed for cells, and treatment may include chemotherapy, radiation, or pleural disease. Pulmonary embolism could be concerned, but is less likely given the pleural effusion and lack of ECG findings suggesting an infarction. Pneumonia would present with fever, cough, and productive sputum, and would not typically cause large pleural effusion without signs of infection. Congestive heart failure typically causes bilateral pleural effusions and would also be associated signs of fluid overload, which this patient does not exhibit. These questions are designed to assess critical thinking, clinical knowledge, and the ability to make appropriate decisions based on patient presentations. Each scenario encourages not only identifying the most likely diagnosis, but also determining the correct management plan based on evidence-based guidelines. Question 11. A 45-year-old man with a history of hypertension, obesity, and type 2 diabetes presents with a dull headache and visual disturbances that have worsened over the past few weeks. His blood pressure is 109 to 120 mmHg, and fundoscopy reveals papilledema. Laboratory results show normal renal function. What is the most likely diagnosis, and what is the next best step in management? A. Pheochromocytoma. Order plasma metanphrines and initiate alpha blockade. B. Idiopathic intracranial hypertension. Perform a lumbar puncture to confirm increased opening pressure. C. Hypertensive emergency with malignant hypertension. Initiate Roman antihypertensives and admit to the IQ. D. Pituitary adenoma. Order an MRI of the brain to evaluate for mass effect. Answer: C. Hypertensive emergency with malignant hypertension. Initiate Roman antihypertensives and admit to the IQ. Explanation: this patient presents with severely elevated blood pressure 108 to 120 mmHg and signs of end-organ damage, papilledema, and visual disturbances indicating hypertensive emergency with malignant hypertension. Immediate Roman antihypertensive therapy. G. Labetalol. Nicardipine is required to lower blood pressure gradually to prevent further complications. Pheochromocytoma can cause episodic hypertension with headaches and palpitations, but typically does not cause papilledema. Idiopathic intracranial hypertension is more common in young, obese women and would present with increased opening pressure on lumbar puncture, but it is not associated with severe hypertension. Pituitary adenoma may cause visual changes due to optic chiasm compression, but does not explain the severe hypertension. Question 12. A 32-year-old woman presents with polyuria polydipsia and unintentional weight loss over the past 3 months. She has no significant past medical history. Laboratory results reveal fasting blood glucose of 300 ADH book of 10.2% and the presence of glutamic acid decarboxylase GAD antibodies. What is the most appropriate next step in management? A. Initiate metformin and lifestyle modifications. B. Prescribe basal insulin and encourage dietary changes. C. Start oral sulfonylureas to stimulate insulin secretion. D. Monitor blood glucose and recheck HbAC in 3 months. Answer. B. Prescribe basal insulin and encourage dietary changes. Explanation. This patient has latent autoimmune diabetes in adults. LODA, a form of autoimmune diabetes that presents in adulthood with features resembling type 1 diabetes. The presence of GAD antibodies confirms the autoimmune etiology, and insulin therapy is necessary to prevent diabetic ketoacidosis. Metformin is the first-line treatment for type diabetes but is insufficient for LODA. Sulfonylureas increase insulin secretion but are ineffective in LODA as beta cell function progressively declines. Delaying treatment monitoring blood glucose without intervention would put the patient at risk for complications. Question 13. A 70-year-old man with a history of chronic obstructive pulmonary disease, COPD, presents with worsening shortness of breath, productive cough with purulent sputum and wheezing. His vital signs include a respiratory rate of 24 min, heart rate of 100 min, and an oxygen saturation of 88% on room air. Chest X-ray reveals hyperinflation but no consolidation. What is the most appropriate treatment? Approach: A. Start broad-spectrum antibiotics, nebulized bronchodilators, and corticosteroids. B. Administer loop diuretics and oxygen therapy for pulmonary edema. C. Perform the thoracynthesis to drain pleural fluid. D. Order a ECANI of the chest to rule out a pulmonary embolism. Answer. A. Start broad-spectrum antibiotics, nebulized bronchodilators, and corticosteroids. Explanation. This patient is experiencing an acute exacerbation of COPD, ECOP, which is characterized by worsening dyspnea, increased sputum production, and airway inflammation. Management includes bronchodilators, albuterol, ipratropium, systemic corticosteroids, prednisone, and antibiotics, azithromycin or doxycycline. If purulent sputum. Pulmonary edema would present with crackles, not wheezing. Pleural effusion is unlikely given the absence of fluid findings on X-ray. Pulmonary embolism should be considered if the patient had sudden onset dyspnea without an infectious component. Question 14. A 55-year-old man with a history of alcohol use disorder presents with confusion, ataxia, and nystagmus. His family states he has been drinking heavily and eating poorly. What is the most appropriate immediate treatment? A. Administer glucose followed by thiamine. B. Give romaniamine before glucose administration. C. Start benzodiazepines to prevent alcohol withdrawal. D. Order an MRI to rule out a stroke. Answer. B. Give romaniamine before glucose administration. Explanation. This patient has Wernicke encephalopathy, a neurological emergency caused by thiamine, vitamin B deficiency due to chronic alcoholism and malnutrition. Treatment require romaniamine before glucose to prevent worsening neurological symptoms since glucose metabolism depletes thiamine stores. Benzodiazepines are used for alcohol withdrawal but not correct Wernicke encephalopathy. MRI may show mammillary body atrophy in later stages, but treatment should not be delayed. Question 15. A 62-year-old woman presents with fatigue, constipation, weight gain, and cold intolerance. Her TH is elevated and FreeT is low. What is the most appropriate treatment? A. Initiate levothyroxine therapy. B. Prescribe iodine supplementation. C. Start methimazole therapy. D. Repeat thyroid function tests in 3 months. Answer. A. Initiate levothyroxine therapy. Explanation. This patient has primary hypothyroidism confirmed by an elevated TH and low FreeT. The treatment of choice is levothyroxine synthetic replacement. Iodine deficiency is rare in developed countries. Methimazole is used for hypothyroidism, not hypothyroidism. Delaying treatment is unnecessary given the clear diagnosis. Question 16. A 29-year-old woman at 32 weeks of pregnancy presents with sudden onset severe headache, right upper quadrant pain, and visual disturbances. Her blood pressure is 100 to 100 mmHg, and laboratory tests show thrombocytopenia, elevated liver enzymes, and proteinuria. What is the most appropriate management? A. Tolroman, libetalol, and deliver the baby immediately. B. Prescribe oral antihypertensives and bed rest. C. Perform plasmapheresis to correct thrombocytopenia. D. Roman antibiotics for possible infection. Answer: Hysteromen ibetalol and deliver the baby immediately. Explanation: this patient has HELLP syndrome, hemolysis, elevated liver enzymes, low platelets, a severe complication of preeclampsia. The definitive treatment is urgent delivery to prevent maternal and fetal complications. Roman antihypertensives, labetalol or hydralazine, and magnesium sulfate for seizure prophylaxis should also be initiated. Question 17. A 65-year-old man with a history of coronary artery disease, hypertension, and type 2 diabetes presents with sudden onset chest pain that started 30 minutes ago. The pain is substernal, radiates to his left arm, and is associated with diaphoresis and nausea. His blood pressure is 104/9 mmHg, heart rate is 78 min, and exjacent segment elevations neuroman Romnanaf. What is the next best step in management? A. Administer sublingual nitroglycerin and repeat EC in 30 minutes. B. Roman heparin. Start dual antiplatelet therapy and urgently consult cardiology for reperfusion therapy. C. Obtain a chest X-ray to rule out aortic dissection before starting anticoagulation. D. Prescribe aspirin and discharge without patient follow-up. Answer: B. Roman heparin. Start dual antiplatelet therapy and urgently consult cardiology for reperfusion therapy. Explanation: this patient has an elevation myocardial infarction STEMI with findings of inferior wall infarction elevation Roman Tomrenef. Immediate management includes aspirin plus pi inhibitor, clopidogrel, ticagrelor, anticoagulation, heparin, emergent reperfusion via percutaneous coronary intervention (ECI) within 90 minutes, or fibrinolysis (ECI) is unavailable. Question 18. A 25-year-old woman presents with fatigue, weight loss, palpitations, and heat intolerance over the past 2 months. On exam, she has the diffusely enlarged, non-tender thyroid and a fine tremor. Laboratory results show low TH and elevated free thyroid-stimulating immunoglobulin. Size positive. What is the most appropriate initial treatment? A. Levothyroxine therapy. B. Methimazole or propylthuracil P2. C. Radioactive iodine therapy. D. Total thyroidectomy. Answer: B. Methimazole or propylthuracil P2. Explanation: this patient has Graves' disease and autoimmune hyperthyroidism caused by Psi activation of the thyroid gland. Methimazole, preferred, or 2 if pregnant, is the initial treatment to control thyroid hormone levels. Radioactive iodine therapy is considered for definitive treatment but is not first line for newly diagnosed cases. Thyroidectomy is an option if medication, radioactive iodine fail, or if malignancy is suspected. Question 19. A 72-year-old man presents with progressive memory loss, difficulty managing finances, and getting lost in familiar places. His family notes he has become more irritable and has difficulty finding word. MRI of the brain shows cortical atrophy, particularly in the hippocampus and temporal lobes. What is the most likely diagnosis? A. Vascular dementia. B. Frontotemporal dementia. C. Alzheimer's disease. D. Normal aging. Answer: C. Alzheimer's disease. Explanation: Alzheimer's disease is the most common cause of dementia and presents with early memory impairment, hippocampal atrophy and MRI, executive dysfunction and word-finding difficulties, temporal lobe atrophy, language and cognitive decline, beta-amyloid plaques and tau tangles, pathologic hallmark. Question 20. A 58-year-old man with a 30-year smoking history presents with hemoptysis, weight loss, and persistent cough. Chest X-ray reveals a 3 cm mass in the right hilum, and biopsy confirms small cell lung cancer. What is the most appropriate initial treatment? A. Surgical lobectomy. B. Chemotherapy with cisplatin and etoposide. C. Radiation therapy alone. D. Palliative care only. Answer: B. Chemotherapy with cisplatin and etoposide. Explanation: small cell lung cancer (SLC) is an aggressive, centrally located tumor often presenting with paraneoplastic syndromes e.g. Lambertitan. Chemotherapy is the mainstay. Cisplatin plus etoposide, as SLC is usually metastatic at diagnosis. Surgery is not an option due to rapid spread. Radiation is used only for local control or brain metastases. Question 21. A 40-year-old woman presents with sudden onset right-sided weakness and difficulty speaking. She has a history of migraines with aura but no other risk factors. Brain MRI shows multiple small infarcts in different vascular territories. Further workup reveals an atrial septal aneurysm with a pattern foramen in ovale foe. What is the most likely cause of her stroke? A. Atherosclerosis. B. Cardioembolic stroke from paradoxical embolism. C. Hypertensive intracerebral hemorrhage. D. Vasculitis. Answer B. Cardioembolic stroke from paradoxical embolism. Explanation: a foot allows venous thrombi to bypass the lungs and enter systemic circulation, leading to a paradoxical embolism. Stroke in a young patient with no significant vascular risk factors, but a history of migraine suggests this mechanism. Question 22. A 60-year-old man with chronic kidney disease presents with fatigue and pallor. His hemoglobin is 9.5 grams. Storm CV is normal and reticulocyte count is low. What is the most appropriate treatment? A. Blood transfusion. B. Oral iron supplementation. C. Erythropoiesis-stimulating agent ESA. D. Bone marrow biopsy. Answer C. Erythropoiesis-stimulating agent ESA. Explanation: this patient has anemia of chronic disease act due to kidney disease from reduced erythropoietin production. ESA G. Epoetin alpha is the treatment of choice when Hb 10 grams store. In is only given if iron deficiency is present. Question 23. A 30-year-old man presents with bloody diarrhea, fever, and abdominal pain. Colonoscopy reveals continuous inflammation from the rectum to the sigmoid colon. What is the most likely diagnosis? A. Crohn's disease. B. Ulcerative colitis. C. Irritable bowel syndrome. D. Infectious colitis. Answer B. Ulcerative colitis. Explanation: ulcerative colitis features continuous colonic involvement starting from the rectum, bloody diarrhea and systemic symptoms, risk of toxic megacolon and colorectal cancer. Question 24. A 55-year-old woman presents with polyuria, polydipsia, and hyponatremia. Now 150 meckel. Serum osmolality is high, urine osmolality is low, and water deprivation test shows no increase in urine concentration. What is the most likely diagnosis? A. Primary polydipsia. B. Central diabetes insipidus. C. Nephrogenic diabetes insipidus. D. SIAD. Answer B. Central diabetes insipidus. Explanation: Senelicolacai. High serum osmolality, low urine osmolality. Water deprivation test fails to concentrate urine. Treatment: desmopressin synthetic. Question 25. A 70-year-old man with atrial fibrillation is found to have a new stroke. His chance VASC score is 5. What is the best long-term stroke prevention strategy? A. Aspirin therapy. B. Warfarin or DOAC. G. Apixaban. C. Clopidogrel. D. Carotid endarterectomy. Answer B. Warfarin or DOAC. G. Apixaban. Explanation: patients with and chance VASC2 require anticoagulation to prevent embolic stroke. DOAC. G. Apixaban, rivaroxaban are preferred over warfarin. Question 26. A 45-year-old woman presents with progressive shortness of breath, non-productive cough, and fatigue over the past 6 months. She has no history of smoking or environmental exposures. On examination, she has bilateral lung crackles but no peripheral edema. High-resolution CT of the chest shows bilateral reticulonodular opacities, primarily in the lower lobes, and honeycombing. Pulmonary function tests show a restrictive pattern with a decreased diffusing capacity DLEA. Which of the following is the most likely diagnosis? A. Chronic obstructive pulmonary disease, COP. B. Pulmonary embolism. C. Idiopathic pulmonary fibrosis. D. Sarcoidosis. Answer C. Idiopathic pulmonary fibrosis. Explanation: is patient presents with progressive dyspnea, dry cough, and restrictive lung disease with classic honeycombing on CT, strongly suggesting idiopathic pulmonary fibrosis. It is a chronic progressive interstitial lung disease characterized by fibrosis, restrictive lung function, and reduced DSEA. Treatment includes antifibrotic agents, pirfenidone, nintedanib, and in severe cases, lung transplantation. Question 27. A 32-year-old woman presents with unilateral headache, jaw claudication, and scalp tenderness. She reports blurry vision in her right eye that started a few hours ago. She has no significant past medical history but notes recent proximal muscle pain and stiffness in her shoulders and hips. Physical examination shows tenderness over the right temporal artery. What is the most appropriate next step? A. Immediate temporal artery biopsy. B. High-dose corticosteroids. C. NSAIDs outpatient follow-up. D. MRI of the brain. Answer B. High-dose corticosteroids. Explanation: this patient has giant cell arteritis GA, a large vessel vasculitis that can cause irreversible vision loss due to ischemic optic neuropathy. Key symptoms: headache, jaw claudication, scalp tenderness, visual loss, and polymyalgia rheumatica PMR. Association: immediate treatment with high-dose corticosteroids. Prednisone 4060 mg daily is required to prevent permanent blindness. Temporal artery biopsy confirms the diagnosis but should not delay treatment. Question 28. A 65-year-old man with a history of chronic kidney disease (CAD) and diabetes presents with generalized bone pain and muscle weakness. Labs show calcium 8.2 ddl low, phosphate 5.5 mdl IEH 900 fit pgml elevated, vitamin D low. Which of the following is the most likely underlying cause? A. Osteoporosis. B. Paget's disease. C. Secondary hyperparathyroidism due to CKD. D. Multiple myeloma. Answer: C. Secondary hyperparathyroidism due to CKD. Explanation: this patient has chronic kidney disease, mineral and bone disorder (EED) due to secondary hyperparathyroidism. CKD leads to phosphate retention, decreased vitamin D activation, hypocalcemia, increased pH release. High PTH causes bone resorption, leading to osteomalacia and bone pain. Treatment includes phosphate binders, vitamin analogs, and calcium supplements. Question 29. A 50-year-old woman with a history of systemic lupus erythematosus, SLE, presents with fatigue, pallor, and jaundice. She reports no recent infections or medication changes. Physical exam reveals sclerolicterus and mild splenomegaly. Labs show hemoglobin 7.8 grams still. Reticulocyte count elevated. LDH elevated. Haptoglobin low. Direct Coombs test positive for Ig and complement. What is the most likely diagnosis? Say iron deficiency anemia. B. Autoimmune hemolytic anemia (AHA). C. Thrombotic thrombocytopenic purpura (TEP). D. Paroxysmal nocturnal hemoglobinuria E8. Answer: B. Autoimmune hemolytic anemia (AHA). Explanation: this patient has warm autoimmune hemolytic anemia (AHA), commonly associated with SLE. Positive Coombs testing and complement confirms immune-mediated hemolysis. Low haptoglobin and high LDH suggest hemolysis. Treatment includes corticosteroids as first-line therapy. Question 30. A 40-year-old man presents with painless jaundice, weight loss, and dark urine over the past 2 months. He has no history of alcohol use or hepatitis. On examination, he has palpable, non-tender gallbladder Courvoisier's sign. CT abdomen reveals a 3 cm mass in the head of the pancreas with bile duct dilation. What is the most likely diagnosis? A. Hepatocellular carcinoma. B. Gallstone-related obstructive jaundice. C. Pancreatic adenocarcinoma. D. Autoimmune hepatitis. Answer: C. Pancreatic adenocarcinoma. Explanation: pancreatic cancer, especially in the head of the pancreas, presents with painless jaundice, weight loss, and a palpable gallbladder Courvoisier's sign due to bile duct obstruction. Smoking and chronic pancreatitis are key risk factors. CT scan is the first-line test. Definitive treatment is Whipple procedure, surgical resection if non-metastatic.